Hello, good afternoon, everyone. Welcome to beautiful Charlotte, North Carolina, and EMS Today 2018. I'm Sarah Ferguson. I'm a senior editor for GEMS. And welcome to our panel discussion sponsored by Boundary Medical on how to prepare communities to stop the bleed. If you didn't get scanned in for this session, please see the attendant outside the door immediately. Otherwise, you'll be unable to get CE credit for this session. So this is our second ever EMS Today live panel simulcast. Not only do we have all of you here today, we're also broadcasting this panel live over the internet to over 1,000 registrants. So welcome to our online audience as well. In October of 2015, the White House launched its Stop the Bleed campaign, a special national initiative designed to provide bystanders with the tools and knowledge to provide immediate and effective hemorrhage control. Similar to the use of AEDs, the goal is to empower the general public to be aware of the simple steps that can be taken to stop or slow life-threatening bleeding and to promote the general public's access to bleeding control kits in public spaces. In today's panel discussion, sponsored by Boundary Medical, you'll hear firsthand accounts from the EMS personnel who were on site on October 1st, 2017 at the shooting in Las Vegas, and how invaluable civilian and bystander support was in controlling severe hemorrhage on that tragic evening. Our panel will provide an update on the federal Stop the Bleed initiative and where it's headed in the future, and then they will discuss how the state of Arkansas secured funding to implement a statewide Stop the Bleed program that involves EMS, law enforcement, school nurses, teachers, and church groups as trained first responders. So just a few housekeeping notes for our online audience before we get started with our panel. If you have any questions during the webcast, click on the Q&A widget at the bottom of your console and submit your question at any time. So we'll be answering all questions. We'll take all questions from both online and our in-person audience during the Q&A portion at the end of our session. This webcast will also be archived at gems.com/webcasts within 48 hours, so you can view it again and share it with your colleagues. And now I'd like to introduce our speakers. Brian Rogers serves as partner and Chief Operating Officer for Community Ambulance in Southern Nevada, where he is responsible for all operations of the company. Brian began his career in EMS in Las Vegas as a paramedic for Mercy Ambulance in 1988. He launched Community Ambulance in 2010, and the company now has over 275 employees and is recognized as an industry leader in Southern Nevada. Dr. Richard Hunt is the Senior Medical Advisor for National Healthcare Preparedness Programs at the U.S. Department of Health and Human Services. He served as the White House Director for Medical Preparedness and Response Policy from 2013 to 2015. There he played critical roles in the response to the Ebola crisis and led the Stop the Bleed initiative. Dr. Hunt is board certified in emergency medicine and is also an adjunct professor of emergency medicine at Emory University. John Swanson is the Executive Director of the Arkansas Regional Metropolitan EMS System. He recently led an effort to provide training on tactical emergency casualty care to more than 3,000 state and local law enforcement officers. Major Clayton Goddard is a nationally registered paramedic and certified law enforcement officer in Arkansas. Major Goddard currently serves as the Special Operations Supervisor for Metropolitan EMS in Little Rock, where his responsibilities include recruitment, training, and response operations. And with that, Brian, I'm going to hand it over to you.
Thank you, Sarah. And thank you for letting me be here this morning. My name is Brian Rogers. Community Ambulance has been in business for about 8 years now, but in Las Vegas, my partner and I have been working in EMS for almost 30 years. We just got tired of the status quo and decided to do something a little different, so we developed Community Ambulance. In Las Vegas, there's not a weekend that goes by, most of the time not a weekday that goes by, where there's there's not some kind of special event. So although community does non-emergency transports and facility transports, 911 transports, we also do special events. And just to clarify, I'll give you a little geography because people do get very confused. When we talk about Las Vegas, the Las Vegas Strip is in Clark County. So you'll hear me talk about Clark County Fire Department. And the city of Las Vegas is downtown Las Vegas. So on that fateful night, 1 October, this was the third night of the event. The event had 22,000 attendees. Like I said, it was a 3-night event. During the first 2 nights, we transported only 8 people. It was actually a very successful event. We had a total of 16 paid personnel on scene, but we also had several, exactly 5, employees on scene that were enjoying the concert. And those employees had worked previous nights of the concert. Just want to make sure I don't miss anything here. So at about 21:10, before the EMS system was activated, and I know there's been a lot of time frames thrown around. I'm just giving you mine. It's never going to be the official one, but this is, I got a phone call from my daughter, who also works for community in a support fashion, and she said, "Dad, they're shooting at us." I had no idea what she was talking about. She said it again, and I'm like, uh-oh. So at that point, we initiated a response. Community ambulance had 3 ambulances on scene and 1 supervisor on scene. Like I said, there was a total of 16 on duty and 5 off-duty personnel. 22,000 people, and the shooting lasted for about 10 minutes before anybody could get there. Those 21 people were on scene by themselves, and we have a dual response system in Clark County. So the fire department and community would go to these events. But just like we're taught, everybody stayed back. No one's going to go into an active shooter event. And I can tell you, after speaking to these 21 that were there, they felt like they were really on an island. They were on their own, and they had to figure it out. And I couldn't be more proud, because they figured it out, and they learned how to make bystanders physician extenders. And just because I can, I just like to tell you the 21 that decided to stay there and not run are sitting in these first 2 rows right here. We got to bring them here to the EMS Today show, and I'm very, very proud of all of them. Thank you. And the ingenuity, I'll be honest with you, we had no idea about Stop the Bleed, or at least I didn't. We did nothing formal with Stop the Bleed prior to October 1. But they exhibited ingenuity. All bystanders wanted to help. Like I said, they felt like they were on an island, but those that were not injured were asking, "What can we do to help you?" And they took them up on the offer. We went through all of our our commercially available type equipment. We went through all of our CAT tourniquets, all of our gauze. And part of the problem was you had so much equipment in the medical tent that we have, the rest of our equipment was out in the ambulance. Well, in order to get to the ambulance, now you had to run through gunfire. And to be perfectly honest with you, we have one young lady down here that did that just to get some more equipment. And we used everything. They were teaching people how to put tourniquets on the fly. So for every one of them, you figure they were telling 10 people what to do. So there's 16 of them. Now I have 160 people taking care of bystanders. Also, we could never, ever, ever get all these people to the hospital that quick. These guys were directing and putting people in personal vehicles, putting people in personal pickup trucks, and getting them out. Before EMS or fire was ever allowed to come into the scene, I bet you a good 200 people were transported out of the scene in private vehicles. They showed what it really took to take care of a lot of people. Like I said, I know one gentleman right here, Oscar. He's a combat medic. He has experience. They were cutting up their stethoscopes to make tourniquets and handing them to people and saying, "Here, make a tourniquet." You know, they were packing wounds. Like I said, there was nothing official about what we did. It had nothing to do with Stop the Bleed, but it sure mimicked it. And they got everybody to the hospital. And when we look at this, I want you to think about that night. It was very early. It was reported, and I say 58 dead and 1 SOB, but that's just me. With that number, all those other people that made it to the hospital, there wasn't that many that passed away, except for the ones that were pretty much expired on arrival. And that's because of these guys and the bystanders that they used to make sure these people got the care they needed. And I just couldn't be more proud. What are we doing now? Once again, I can't take any credit, but some of the employees that were there have decided that Stop the Bleed is going to be our initiative. They realize how important it is. Jeff Yost, who's somewhere out here, I kind of looked for him, but I can't see him. He's taken it upon himself, working with a few other employees, and he became an instructor. And now on the 31st of March, it's National Stop the Bleed Day. We're partnering with our Las Vegas Metropolitan Police Department, and we're going to offer classes to the public. Right after we do that, we're going to offer classes to the officers and the support staff. Then we want to get all the hotel security guards and everybody else we can get, because although we did not formally know this, we realized that night how Stop the Bleed can save lives. There's no two ways about it. It saved lives. And these guys, they figured it out on their own, on the run, and they made it happen. And, you know, it's amazing to me that Stop the Bleed was out there. It was exactly what we should have taught people before this, but lesson learned. And now it's our goal to teach as many in Southern Nevada how to stop the bleed before we ever need it again. I'd like to say thank you and introduce Dr. Richard Hunt.
Thank you, GEMS and Boundtree, for doing this. It's important. The White House in October 2015 launched Stop the Bleed. It had a vision, a twofold vision: save lives and build resilience. And build resilience. And it had these goals. I'm guessing many of you in this room may be hearing these 5 goals for the first time. The general public will know the phrase "Stop the Bleed" and its associated logo. The general public will know how to stop life-threatening bleeding. The general public will have access to effective personal bleeding control kits. The general public will have access to effective public access bleeding control kits. And every bleeding control kit will provide just-in-time audio and visual training. 5 goals. The operative word there, or 2 words there, and there was 5, is something different for us in EMS. The general public. And by the way, our general public, last time I looked at the census, 325 million people. That's pretty ambitious. 325 million people. Okay? The general public. Wasn't about hospital employees. It wasn't about EMS providers. It wasn't about fire, public safety, school nurses. It was about the general public, 325 million people. So, first goal. General public would know the phrase "Stop the Bleed" and its associated logo. Why is that so important? It's the anchor. It carries the campaign. And why is the logo itself important? The logo itself. It's important. What's in the middle of the logo? At the physician leadership meeting we convened at the White House, the president of the American College of Surgeons rose his hand, and he says, it's this. It's the direct pressure piece. And lots of bleeding can be controlled with the hand. So creates muscle memory, okay? Creates muscle memory. So you see the logo, oh yeah, stop the bleed, and oh yeah, that hand thing. The Stop the Bleed logo is trademarked. With the Federal Interagency National Security Council staff convened work group, the Department of Defense rose its hand and said, yep, we'll work on the logo. And we said, you know what? That logo can't be used for bad purposes. And how many times have we seen logos used for things that it was not intended for? It's therefore trademarked, okay? It's trademarked by the Department of Defense, and the Department of Defense has entered into over 200 public and private sector agreements. And you say, well, that's not very many. Well, you're talking 325 million. You can have a personal agreement. I've got a personal agreement with them. So we're talking very, very large entities have entered into this agreement. It's not a 6-month lawyer deal. It's like, okay, send them the agreement. It's pretty straightforward and clear. It says you shouldn't be using it for bad purposes, and you're good to go. Take out your iPhones before I switch the slide. Capture the email address and get you the agreement and use the logo. The logo, yeah, it's associated with programs like this, but gosh, one of the best uses I've seen the logo, University of Georgia campus buses had the logo on it, Stop the Bleed, okay? So email Ramin, tell him I sent you, get your agreement, okay? It's a to-do item. The general public will know how to stop life-threatening bleeding. One organization, and many organizations have really worked hard on Stop the Bleed. Many organizations have really just like jumped in. My guess is many of you in the audience have been participants in getting the word out and teaching. And in terms of courses and classes that have gone on, goodness, really exceeded expectations. One organization, the American College of Surgeons, has, again, one organization, there are many, 12,000 instructors, 70 or greater than 7,000 classes in 50 states, and an unintended positive consequence, 56 countries. Colleges, high schools, junior schools, there have been some primary schools where Stop the Bleed has already started to percolate. And the initiatives from Arkansas you're going to hear about, initiatives in Georgia, statewide. There's a really critical word in this goal, okay? And it's know how to stop life-threatening bleeding. Know. And what do we know? In medicine, in EMS, we know training, education, classes. That's what we do and what we know. And if we've learned anything from our initiatives in CPR, AEDs, we'll never get to the entire general public, 325 million people, with classes alone. It just can't happen. So we got to start thinking really out of the box with some novel solutions. And that gets way out of our comfort zone with education, and it gets to things like pop-ups. And it gets to things like Stop the Bleed days. And it gets to things like this.
You've probably seen these boxes on our set. They're bleeding control kits.
And they're part of a new White House initiative. Soon, you'll be seeing them on the walls of public spaces.
Airports, shopping malls, even your place of business. Open the box and you will find what you need to stave off a bleeding wound
and give the victim time for help to arrive.
These are items that you should also have in your home and car.
The kit comes with gauze, scissors, and a tourniquet,
as well as gloves to protect you and the patient.
Often holding pressure firmly against a wound or wrapping it tightly will stop the bleeding.
But in more severe cases, a tourniquet may be required.
It should be flipped on the limb and fastened above the bleeding wound. Then use a plastic rod to tighten it until the bleeding stops. Once applied, the patient should be taken to the hospital and the tourniquet removed by medical personnel only.
Make sure you call 911 first. For more information and instructional videos, please visit these websites.
You can save a life by learning how to stop the bleeding.
CVS cares.
That public service announcement was a generous contribution by the cast of Code Black, executive producer of Code Black, and CBS Network. It was shown in October last year, October 12th, after the airing of the Code Black episode. The actual script for it and the negotiations around the content of it were done with representatives of the bystander work group convened by the National Security Council. It's technically accurate with one exception. I'm guessing many caught it in the room. It's not life-threatening bleeding, and guess what? If we'd shown that, they would have shut off the TV, and the people who saw it probably would have shut down and not caught the message. So we did it purposely that way. It's in the public domain. You can download it, and one of the things that is most fascinating is I keep seeing every day I get a Google feed on Stop the Bleed, and I see multiple local TV stations that have highlighted the classes that have gone on and the initiatives that are underway across the country, and it's like, yes, and if you just took the video, the PSA, don't even spend, your time in terms of advertising time, but couple it, you would have amplified the message and shown technically accurate, this is how you do it. Now, are there studies about, oh my goodness, well, this actually works because people remember something? You know what? You can study it till the cows come home. But my thought is that if you at least have some exposure to it, in the moment you will reach down really deep and try to remember some of that stuff, and maybe it'll do some good. Awareness alone helps, okay? That video, in terms of its impact and the power of engaging media was seen that night, I'm not talking about all the repeat plays, by 5.6 million people. 5.6 million people. It's not our comfort zone, but we got to get out of it and figure out how to engage the media to get Stop the Bleed into the hands of the people that will actually be able to save lives, because we can't get there in time. We just can't get there in time. The general public will have access to effective bleeding control kits. This is one graphic. There are many effective bleeding control kits out there by many different companies. It's not to advertise one or the other. I'm extraordinarily gratified by the energy put into this by the corporate sector. We had a corporate sector meeting at the White House to discuss how we were rolling this out. The minimum contents, minimum contents, okay? You can add what you want, but realize the complexity sometimes makes it a little bit harder to actually perform. So minimum contents, as discussed by the National Security Council, bystander group, were effective. An effective tourniquet. Yes, there are counterfeit tourniquets. That thing actually exists. 6-inch dressing, S-rolled gauze, trauma shears, gloves, and a bag. Make accessible to all. Make accessible to all. And why is that so important? If a soccer mom or dad goes into a store and actually says, oh, this kit, it's not just first aid, but it actually will save a life, and I'm going to actually buy it. There's some familiarity with that. And that familiarity in their family's horrible event or a big event will carry the day, that familiarity, okay? So, make accessible to all. You know, you say, well, I would say that the retail sector hasn't been penetrated very well, certainly online. Why not the retail sector? And you say, well, the retail sector is going away. Well, guess what? People are still probably for a while going to grocery stores and drugstores, I think, unless I'm missing something. So that one's hard. And then economies of scale, the pricing, we've got to get to a point where it's accessible to all. The general public will have access to effective public access bleeding control kits. Conceptually, multiple personal kits in one package. I was gratified to hear while I was in Las Vegas learning about the challenges and the profound successes you actually had that night. The concept of throw kits where you actually like take an individual kit and you throw it to a member of the general public who is actually wants to help. Multiple individual kits in a large kit, okay? So that becomes a public access kit. And then next to AEDs, you know, I saw downstairs, there's some like kits down there, and I'm looking around here in the hallways with the AEDs. If you don't want to like do the, you know, return shipping thing, you might want to just like drop one off of there. Charlotte Airport actually, if you take a look when you're on your way home, every AED at Charlotte Airport, International Airport, has a bleeding control kit right next to it. Why next to AEDs? It puts a spotlight, a brighter spotlight, and amplifies the power of both to save lives. Every bleeding control kit will provide just-in-time audio and visual training. I would say we're so far behind, so far behind. There's been some really good beginning efforts, really good beginning efforts. But if a voice inside a box can instruct someone to deliver a life-saving electric shock, that same voice ought to be able to help somebody stop the bleed. And I'm pretty convinced, just through the experience of this whole Stop the Bleed initiative, that the visual cues are extraordinarily important with the tourniquet skill. And then one last slide, and I put this up there. Usually I just say it, but I put it up there in writing. There are many competing priorities nationally. If you just take a look at, you know, causes of death, opioids, cardiac arrest. And I was challenged in a pretty profound way while we were working on this initiative. Why would we want to spend time and energy on this at a national level? Why would we want to do that? And we started looking at numbers. We started looking at cost-benefit analysis, and the numbers weren't adding up. And so I called a friend and colleague at Harvard's Kennedy School of Government who wrote lessons from the Boston Marathon bombing, Why Was Boston Strong? And I said, you know, I'm not sure we're going to be doing this because I can't make the numbers work. And I got people asking me, why is this so important? Why is this so important? And this was the turning point. He said to me, not just said, pretty much shouted at me, Rick, our challenge and opportunity is not just about saving lives from immediate life threats. It is not just about cost-benefit analysis. And it goes far beyond increasing survival from daily and catastrophic tragedies. It is about building resilience of people through increasing personal and community efficacy and effectiveness. It is about building on a foundation of the public's propensity to act and willingness to intervene. And it is about building a community narrative, speaking to the notion of a nation of people who are self-propelled and who have a spirit of taking care of each other, especially in their most desperate moments of need. This is who we are as a nation. With that, thank you for your kind attention. I'd like to please turn this over to Clayton. So let us learn about Arkansas. Thank you.
Good afternoon, everybody. I was asked, along with my boss, Mr. Swanson, over here, to talk about some of the success of the implementation of bleeding control programs in Arkansas. We've had quite a bit of success in implementing not only into law enforcement, but schools, but into our communities. And my hopes is that maybe I can soften or provide some methods that might decrease some of the challenges. And there are challenges in our system, and we faced those when we started our program at the end of 2013 and now moving into 2014. When you look at our current response system, and this was a statement up there, and you read it yourselves, but think about it. Everybody, look across the audience, a lot of young people. From day one, you have to understand in our response system, what are the issues that we can improve upon? And from day one, you've either been taught, call 911, or you've taught your children or grandchildren, call 911, and your professional responders are on their way and they're going to solve the problem. The incidences as Las Vegas, Sandy Hook, and all these active shooter, active aggressor incidents have made us take a hard look at what are the weak points of our system. And we figured it out. The expectation is when you call 911, you, the paramedic, Oscar, you're going to show up and you're going to fix all the problems. But the weakness of our system is that we're not always there in the first 0 to 10 minutes when the cardiac arrest has occurred or the life-threatening hemorrhage has occurred. And that's one of the key points that we looked at in Arkansas. Arkansas's program was not geared towards active shooter, even though, and I'll explain in a minute, we reached out to law enforcement first. It was how does Clayton the paramedic or Andrew the firefighter, how can we extend our capabilities? So we really looked at engaging our bystanders from the very beginning. One thing you have to understand, and like I said, it's these large mass casualty incidents that draw our attention, but all of us are faced with an imbalance between capability and capacity, okay? Your firefighters, my EMS partners out here, doctors, nurses, hospitals, law enforcement, you're trained to a high level. You have the tools to make a difference, but it doesn't take a shooting in Las Vegas or Sandy Hook or Columbine to show you that your system can't handle a capacity. It can take a system where you have a rollover of a church van to realize I don't have enough resources at the time. It can take a multi-vehicle accident where I have 3 patients that will overwhelm most of your rural EMS systems. But our system was built around, we're going to respond, and you'll get all 3 agencies on scene, but the expectation still is EMS, you fix the problem. And we fail in that regards. And it's these incidences that have made us look at our system a little bit further and figure out how do we need to adapt to these problems. In 2013, Arkansas was looking at trauma, and you can see from the slide where our failure points are. And as EMS professionals here, as medical professionals here, we realize not all hospitals are created equal. But it was the system that we worked in where we just took the patient to the closest hospital. There was no reason to push that patient to the most appropriate trauma system. No matter where you go in the United States, in your state, doesn't have to be Arkansas, or in the country, when you think about your response system, EMS has always been your limited resource, and the onus has always been placed on you. And Arkansas took a hard look at trauma in our state, and we developed a statewide trauma system, which is kind of unique. You have a lot of communities, maybe areas of your state or your city that has a trauma system, but Arkansas has a statewide trauma system. And when they started implementation of getting the patient to the right hospital and making sure it was a trauma system, and whether it went to a lower level hospital and was quickly moved to a higher level, it made a difference in our system. You know, the one thing that you're aware of, but you may not, that is so critical to this program, and it's an important teaching point when you go back in your communities. The #1 cause of death in the United States for those ages 1 to 45 is trauma. It is trauma for those folks, and the military has taught us great lessons there, and that was key to our program. To implement a good program into your state, into your community, you need to understand the military's TCCC. tactical combat casualty care, you need to understand the lessons that our military have taught us. You could put it in percentages like you see here. Prior to the implementation, prior to the military changing the way they taught trauma, you had a preventable death rate of 24.1%. 24.1% of our soldiers died from these non-lethal injuries, whether it be penetrating trauma or some sort of amputation, etc. With the implementation of TCCC in the military, you dropped that preventable rate down to less than 3%. Was it because of a change in training? Yeah, it was. Who out here is not using approved frontline tourniquets? Who out here is not packing wounds for hemorrhage control? This is something the military's done across the board since about 2009, and you can see statistically the difference it's made. When we started teaching this in Arkansas, we took these data, this information, but we gave it back to our law enforcement. We gave it back to our bystanders, our nurses, and we put in context they already knew. How many out here are familiar with Wounded Warrior Projects, Sheepdog Projects, and everything else? You know, the bystander, and maybe some of you as responders, you already knew the percentages if you haven't looked at the papers. You think when you see these organizations and the great work they're doing, you're saying, oh my goodness, so many of our soldiers who have paid the price for developing new methods in trauma like that are being injured in the war on terror, and that's not the truth. The truth is so many of our soldiers are now coming home alive. And that's a key point when you put this in your community. Does this work? Everybody in this room today, you've heard of evidence-based training. Evidence-based training. It's in your ACLS classes, in your CPR classes, it's in your trauma classes, and that lesson was learned in the battlefield. And you need to have a good understanding of TCCC. And when you look at the Stop the Bleed program, some of you may be already teaching it, but this is not a clinical medicine program. It's a side-of-the-road dirt medicine program, as evidenced by my friends here from Las Vegas. I applaud you. One of the key points of this proposal, and Dr. Hunt talked about, is not just how much can you do, and not just so much how much hands-on the bystanders can do, but your ability to direct others, okay? You're not going to get a buy-in from every law enforcement officer. You're not going to get a buy-in from every teacher and everything else. They didn't choose the medical profession to put hands on a bloody wound. But if they understand the program and are willing to take the program, or as a leader in the community or a superintendent or principal in the high school, if they understand the program, there is a role that everybody in your community can make, whether it be hands-on or finding funding for equipment, or in the case of an incident like you guys had, can I direct others to do more work? We as bystanders, and I'll step back, when we started looking at our program, there's two keys to developing a successful program, and we didn't know these on the front end. We knew these as we started to move through. Number one is you have to have relationships. You have to have partnerships, and that's hard for professional responders to have, and here's why. Everybody in this room is a Type A individual. You're all Type A. Your law enforcement officers are Type A, your firefighters are Type A, and I'll suffice it to say your nurses and your doctors and your hospitals are Type A too. What's good about that? You're a fixer and a doer. You see a problem and you want to get it done. And some of my background is in the military, so I was taught you fix a problem. But in this, how does it translate to the civilian world? The good thing about being a fix and doer in Type A, you're going to get the job done. What's the bad thing about being a responder and being Type A and being a fixer and doer? Nobody does it better than who? You. And those lines have been drawn in our response system. How hard is it, EMS, to get the bystander help on a routine basis? You have nothing in your policy or procedure that says you cannot utilize a bystander. It's not written in any of your policies. But I've had my FTO say, hey, they tend to get in the way. We don't need them today. Okay, that's a flaw in our system. That's a weakness in our system. How often do you arrive on scene with my law enforcement personnel, fire personnel, and EMS personnel, and even though it all says Las Vegas or Little Rock on their uniform, we tend to stay in our own lanes? Think about it. We each kind of take our job. I could poll you, this entire audience of EMT personnel, and you said, we're just going to talk about active shooter. Is law enforcement going to let you in quickly? That's been a lesson they've had to learn. So you have to understand what the weaknesses of our system are to truly make a difference, and it is about those partnerships, okay? What really helped, and if you're not familiar with this, are the Hartford Consensus Papers. They took the lessons being learned. They looked at the research from the FBI. They looked at the exponential increase in mass casualty, man-made mass casualty incidences, and said, we've got to make a difference. It's the backbone for what we're trying to do. We started our program at the end of 2013, being able to teach TCCC to law enforcement officers, being able now to take some of those skills and apply it to stop the bleed, happened because a group of individuals said our system was not functioning optimally. My boss said he didn't want me to use the word broke, but you get what I'm saying. It's not working as effective as it could be. So you have to have an understanding of the BASIS program to make a difference. In our program in Arkansas, this was our ultimate goal, and you can see how early we started at the end of 2013. This is when finally, and the two key motivating factors for the Hartford Consensus and the development and push into our program were Sandy Hook and the Boston Marathon. Those two incidents kind of woke up our country and said, now we've got to figure out how to make this work. At the end of that time, a group of volunteer stakeholders representing law enforcement, physicians, paramedics, and firefighters, as well as school officials in the state of Arkansas, we came together with this statement and with these two primary focus groups, law enforcement and schools. Our goal in Arkansas from the very beginning was every law enforcement officer, every school in Arkansas. Some of the requirements starting out, and as we started to teach this, we started with law enforcement as our first priority. Why? First of all, when you deal with incidents where you have that responding agency, law enforcement almost always represents the first professional officer on scene. It's your car wreck, it's your domestic, it's your school accident. Law enforcement showing up first. And then when you were talking about mass shootings, active shooter incidents, law enforcement had to learn that there's a role that they play in ensuring survival of patients. If you think about it, and when we taught law enforcement in the state of Arkansas, law enforcement has two primary goals in their careers, security and then investigation. And for a normal call, those are their two priorities. But they've learned that after security, now they have a higher focus in getting the wounded out. And so we started with law enforcement first. As we came back with the training, we pushed this out to every tactical paramedic, every law enforcement officer who was an EMT in the state of Arkansas. We didn't hold on to it. We taught these classes for free. We taught them to doctors and PAs and nurses and EMTs and pushed that throughout the state. And then we started to partner with stakeholders because there's no advantage in the training if you don't have the equipment to do it. And that's a key lesson with the Stop the Bleed program. You got to have kits. So we started, and that's the only way it's going to be sustainable. So we reached out to the Arkansas trauma system. I remember the conversation I had with Dr. Todd Maxson, who works at Arkansas Children's Hospital. He's a surgeon in Arkansas, and I went to him and I said, Doc, we would like $25,000 for tourniquets for law enforcement officers. We're going to teach them the principles of TCCC. I walked in with a lot of apprehension, but in developing these partnerships, Dr. Max said, that's not a problem, Clayton. $25,000 for tourniquets, no problem. And I said, well, first, there is one caveat. They have to be trained. He said, not a problem. If one tourniquet saves one patient, you've paid $25,000. On average, a trauma patient in Arkansas is $25,000 a day. You've paid for that. So finding partners is key. We found funding. We in Arkansas, and this is something to think about, FEMA and Homeland Security, there is funding for every state in Arkansas. We were real quick to make our Stop the Bleed TECC program a funding source, eligible to receive funding. Now, how does that work, especially when you're competing against SWAT teams and urban search and rescue teams and everything else? It was easy. SWAT teams need tactical medicine, right? Urban search and rescue need the latest in trauma care. Fire departments need trauma care. So we blanketed it all together And then the resiliency that Dr. Hunt's talking about fell in this Homeland program. So that was a key statewide. How do you make your state eligible for other funds? But we didn't look there solely. And then we started providing the training. And like I said, as early as 2014, we took the NAMT Law Enforcement First Responder Tactical Casualty Care course. And it's a heavy PowerPoint course. They teach tourniquets and wound packing and airway and everything else, but we geared it towards our audience. I knew in our state I couldn't keep a law enforcement officer in a classroom for 8 hours. Never going to happen. So we adhered to the standard, but we did all the PowerPoint. We talked about active shooter and how do you manage this, and the last 3 hours of the day after we did all our classroom practicals, we put them on the live fire range. And now my law enforcement officers are doing self-aid and buddy drills on the live fire range, moving, communicating, and ultimately realizing my priority of work is security, but as soon as I get security, my patient comes back. That was the buy-in we got for law enforcement. And one more thing, with setting up money funding through trauma system and other stakeholders, at the end of the class, they got their, not just a tourniquet, but this next year now they got a complete first aid kit. Once again, there's no value in the training if they can't do the job. I'll tell you a caveat to that, though. Originally, when we started teaching, my law enforcement officer said, hey, this tourniquet is for me. It's for me. Law enforcement officers have a hard job right now. It's not the best time to be law enforcement. They're scrutinized for every moment. So their initial thought, well, this tourniquet's for me. You're teaching me how to stay alive. Yeah, yes, we are. But if the incident that you showed up first on, there's a difference that you can make, because EMS and fire are still holding back. So we taught that to them. How do you train or pattern the course toward your audience is key. And then we wanted one other safety net. All of your states have probably some sort of Good Samaritan language, some sort of Good Samaritan laws in your state. But I'm asking law enforcement, we're asking law enforcement, whether it be the alert program or TCCC or whatever, you're asking not only to do medical work, but they're being asked, how do you manage this scene? How do they coordinate? Even triage is being asked of law enforcement officers today. So we went to our Arkansas legislature and enhanced our Good Samaritan Act. Did we need to? Probably not, but it was a comfort level for our law enforcement officers. Plus, it was specified that they had specific immunity if they were trained in the class. If you tell them that you get added protection if you're trained, they want this class. They want this class. They want to be able to do it this way, this standard way, so they understand what's going on. And then the last part is, for any program to be sustainable, you have to show the benefits. I already showed you the percentages from the military TCCC. There hasn't been a whole lot of research being done on the effects of programs in your communities, the effects of law enforcement, the effects of bystanders, and what difference they're making on trauma. We understand that if they're doing something the first 5 minutes, it's going to make a difference, but how do you put that on paper? And that's something we're doing now, and I'm going to show you the results of that in just a second. Here's an example of our law enforcement program in Arkansas. So they've been through the classroom, and now they're at the live fire range, and that's the buy-in we needed. That's how we got law enforcement at the table, and we've had over 5,000 officers trained in this. Sustainability, now that program has gone to our law enforcement academies. All of our academies now teach that standard, and we found grant funding, so when those officers get out of the academies, they're now given the tools. It's paid dividends. There's a presentation tomorrow by Mr. Swanson over here about Little Rock's mass shooting, and the value of that program was there was coordination immediately on scene because law enforcement knew what to do. EMS and fire knew how to run into the warm zone and link up and provide that unified command structure. This was huge in 2015, so we'd already been teaching the program for almost a year and a half. But if you're not familiar with this document, if you don't know how to engage your law enforcement and fire partners, this document was huge. The first paragraph of this, as you can read there, says that. But there's some things that are key there in teaching and understanding this. It says traditional practices of first responders need to be realigned and enhanced. That word traditional practices, what we always do. How do we interact on scene with our law enforcement and fire? And why does law enforcement tend to stay out here and fire EMS stand here? Plus, we don't tend to involve our bystanders. And then realigned. I heard in a class earlier today talk about active shooter, and one of the members in the audience said, we should standardize our incident command system. Really? The incident command system's been around since the late 70s by the fire service. It's standardized. You've all had the classes. All your EMS and fire and law enforcement have had the classes. We just don't train that way every day. We don't engage each other because of that type A nature that we have. Here's the proposal that we wrote. Finally, once law enforcement was moving in the right direction, we set out with our goal number 2, which was our schools. And that same group of stakeholders, plus an additional group that had bought in, law enforcement, et cetera, we went to our Department of Education. This is our proposal to the state. It kind of goes like this. We are going to go out and train every school nurse in Arkansas how to be instructors in the Stop the Bleed program. If they will do that and attend the training and then turn around and teach a minimum of their 25% of their faculty and staff, then they get free wall-mounted kits for all of their schools. There's a buy-in there. There's a buy-in there. We also made it easy. We used what was already in place to make it work. Your teachers, they need professional development hours. Your Department of Education can help make that happen. Your nurses, they would come if we gave them CEU hours. You have organizations in your state that will make sure that happens, that it counts towards their training. And then once that happens and they get their kits, now we're working with legislation in Arkansas to make Stop the Bleed a graduation requirement, just like CPR is now. Going through the schools was tactical. It was tactical for us. Schools gave us the pathway to our communities. Those same teachers who are now being trained go to church, go to the grocery store, go to the bank and everything else. So by working with those two groups, now we're pushing this program statewide into every community, as Dr. Hunt was trying to say. Here's what it looks like once we got to our schools. Same thing. By teaching our nurses, we've developed that core group of instructors throughout the state. We secured funding working with the Department of Health, Department of Education, and other entities. You'll notice, same path we did with law enforcement. The two biggest differences, though, were with law enforcement, we started from the bottom up. Now that we got programs and paperwork and research involved, now we got the support of the governor, of the legislation, of the Department of Health and Department of Education, and we found out now that we've put in the hard work. Now all the direction is coming from the top down. It's been far easier with our schools. Provide the training to the schools. Businesses gain buy-in. There's an advantage, and this is another key. We worked with legislation for law enforcement, but we looked at that same legislation, and our proposal is let's define that bystander. They're not bystanders anymore. They're immediate providers. That's just what we've chosen. But you think about it. If you title someone, you've entitled someone. You've given them the will to go do, and that's a huge point. Partners with stakeholders, again, for sustainability, and then research and data. We used current regulations. The Arkansas Safe Schools Act mandated that every school, every year, do some sort of mass casualty drill. They didn't have to do extra to do the program. It was already in place in Arkansas, so that made it easy. One thing key here, though, is when we started talking to the schools and the teachers and like that, it's great that you want Clayton the paramedic to come talk to you or your law enforcement or firefighter to come talk to you, but why not get a skill and learn to do something yourself? And they said, by all means, I'm tired of hearing law officer so-and-so talk every year. You're giving them something to do, and then show them the difference it's going to make. There's the partners that we've developed over time, and you can see the list. And like I said, that's now that we did all the hard work with law enforcement and that's sustainable, it's become easy with the schools and communities. This is the kind of support you've been able to get. A couple of pictures. You can see the value of the program. I like specifically the picture on the left. That was a small rural town community in southeast Arkansas. You're at level 4 hospital, very little capability. but they wanted to become their own stakeholder groups in their county, Ashley County, Arkansas. So on the day that we came down to teach their school nurses and develop more instructors in the area, they invited everybody, law enforcement, a nursing school, all the folks dressed in white. I've got surgeons, I've got firefighters, I got local folks and everything else. And when we left there that day, they said, hey, we're going to form our own committee. And that's part of what Dr. Hunt was saying. You can't ask for the federal government to come fix this problem. You can't ask necessarily your state to fix this problem. It takes resiliency in each one of your communities. You guys are going to go train your community, and you're going to own that, but you're going to see the value of it, and everybody has to be able to step up and do their own thing. At the end, here's a great example of now that the schools participated, we've ensured that it wasn't Clayton Goddard from Little Rock giving the kits to Farmington, Arkansas. We gave those kits to the local EMS and fire and law enforcement because we've shared this is a community response. Here, y'all take the kits, y'all work together. It encourages that community involvement. And then it is a difference maker. Here's an example of a law enforcement officer trained in it. It's almost classic TCCC. That for my EMS folks in here, that's like I gave you a scenario. How would you fix it? This officer showed up first, gunshot wound to the thigh, arterial bleed, beat EMS and fire a long way off, and making a difference. My law enforcement officers, they're getting awards, they're getting medals for this type of stuff. They're getting the positive feedback from the community, and that's been instrumental in this. So is it making a difference? I told you that you have to understand TCC to understand why this training is new and the difference it can be made. After about 3 years of teaching all law enforcement, we went to the Department of Health, we went to UAMS, University of Arkansas Medical Sciences, and said, we've done enough work in the state of Arkansas, it's time to start looking at some of the data. And my surgeons at UAMS, and they're writing this paper right now, they said, okay, Clayton, let's take a snapshot. Let's take a snapshot to see how this translates, this military training translates to the civilian world. And this is what you're looking at. We taught the entire Little Rock Police Department in 2015. They're looking at penetrating trauma only in the city of Little Rock. They went 2 years prior to law enforcement being trained, and then 2 years after being trained. Remember, law enforcement will almost always be first on scene. Ambulances, we don't carry blood products. What you're seeing is almost a six-fold decrease in mortality because they're getting there and stopping the bleeding. That's effective. We told them all the war stories to get them there. Now we're going back and saying, this is the difference Arkansas law enforcement make. It's going to translate to your civilian communities too. Another example, everybody in the military, you could be ordered to do something that works. TCC worked in the military, that like that. In civilian world, money drives, dollars drive. Second part of that study, they decided to take another data point. They wanted to look at whole blood usage in our trauma patients in that same snapshot of one police department, one community in Arkansas. Almost 3 whole units of blood less per trauma patient. And in Arkansas, per day, a trauma patient costs about $25,000 a day. You can equate that use of whole blood and relate it to days in ICU, days in rehab, and now you're putting dollar amounts to it. I show you this not to say, hey, look what Arkansas did, but there are questions. How does this training translate to civilian world? What kind of impact will your bystanders have? What kind of impact will engaging your community have in trauma? I'm hopeful that research like this and others on programs that we're talking about today, this will drive your community. This will drive your state. This will make a bigger impact that now your insurance companies are involved or private entities become involved because we know what it did in the military. We know the impact that you've had in your community, but when you start putting data and dollars to it, this kind of stuff should help you in your efforts going forward. Thank you, Rob.
Right. Thank you. So I think now we have time for a few questions. We have Ryan Kelly is out in the audience, and you have a question from one of our online attendees?
I do, yeah. We have time for only a couple questions, but let's start with one from online. Are grants available to assist in purchasing personal kits or public access kits?
There are, as I mentioned before, we set up Arkansas, our state, to be eligible for FEMA Homeland Security grants. So part of that FEMA Homeland Security deals with public access, medical care, with everything else, and so that was key to us. So yeah, there are federal grants available. Your state needs to be set up for that. But once again, there are other options. When we worked with schools and everything else, as we go into communities, you'll find out you'll have many more private partners. I mean, we had recently a group go out and teach a small community, and in doing so, they offered to teach a local industry out there the Stop the Bleed program. Taught maybe 30 individuals in a private industry. At the end of that industry said, we want to make a difference in our community, and they turned around and for that free education turned around and bought kits for the entire school district at a cost of almost $25,000. So opportunities exist.
Yeah, just to add to that, I didn't feed Clayton those lines, I promise you. But you really articulated exactly what was envisioned with Stop the Bleed when we launched it. A private-public partnership, a partnership. In terms of grants, it's been fascinating to listen to people who have been able to acquire kits through grants, bundled under other initiatives, quite successfully, and the private sector has really stepped up in pretty extraordinary ways that I would have never expected. And when people ask me about this, what I've found is no one that has actually worked to do training or spread the word or get kits out into the public, no one has ever said, well, we just have no idea how to do it. They've all figured it out. So not to worry. It's there. It's just you got to go seek it out.
Let me add one other quick comment about sustainability. And part of what I think has helped make this successful is a partnership with the media and with the police, so that when these tourniquet skills are used in the field, to make a news story about it and have the police recognized for their role in this and give them credit where they've earned it. And that has helped a lot with the awareness of the public with the private partners, because this is in the media, it's in front of them, and they see the success.
Do we have a question in the audience?
Go ahead and raise your hand if we have a question. Hi, Charles.
Hi, thanks, Ryan. For Chief Rogers and Mr. Yost as well, I can only imagine what it's like to have the amount of resources that you have in a metro environment. Think for a moment, though, geographically, and you'll understand this question very well. You're not in Vegas, but you're in Wendover, or you're in Winnemucca, and you still have these events that are taking place. How do we scale this project to the rural service areas and to the rural service offerings? And also with that, is the media playing their role in that partnership of success for getting the word out in this environment as well? Thank you.
If I may respond to that one, because I just want, Arkansas is a very rural state, and you're exactly who this program is aimed for. Because your law enforcement is a tremendous force multiplier. Your schools, the teachers, you can reach out to the churches and your local businesses, and that really is the next phase. It is rural America that will benefit from this tremendously. We're talking about accidents, we're talking about storms, we're talking about industrial mishaps. Rural America is going to benefit from this greater, and that perhaps is where the challenge is, because the buy-in. How do you get the interest in people? And therein is the challenge. Go ahead.
I'll add one more thing. In working with law enforcement in communities, before we started schools, we were working with law enforcement and fire and everything else. We had greater success with your smaller communities implementing the program than we did the large. And the reason why is those firefighters and those EMS and those teachers, they all live side by side. Little Rock was a challenge because such a robust fire, robust law enforcement spread out, even though they see each other, we're so big and the volume is so high, but the smaller communities, it was easier to implement and you'll find your partners quicker. That's been our success.
And look to your state police. They're the ones on first in that bad crash, and it's EMS is how far away?
And I think that's unfortunately about all the time we have for questions. I just want to say thank you to our incredible panel, Brian, Dr. Hunt, John, and Clayton. And thank you again to all of you for participating, and to our sponsor, Boundtree Medical, for your support in making this educational opportunity available. This presentation is going to be archived, if you want to watch it again, on gems.com/webcasts. Within the next 48 hours, so you can watch it again, share it. Thank you so much for attending this live final simulcast, and we hope to see you back here again soon.
Thank you, guys. Gentlemen, I think that was a success.
Hopefully, mission accomplished, let's hope.